the last speaker. Dr. Jeff Milson needs no introduction, but nevertheless, I'm going to give a quick one. He's the Jerome DeCoste Professor of Surgery here at Weill Cornell. He's co-director of the Center for Advanced Digestive Care, and he's definitely an internationally renowned expert and pioneer in minimally invasive surgery and laparoscopic endoscopic technology. And even more so, you'll hear today about the new ideas that he's coming up with. Jeff, your name came up during some of the talks earlier already, so people have heard about some of your work, and he will be talking today about Seeing is Believing, the PI3 Advanced Imaging Program.
Okay, thank you for that introduction. And I can share a screen, right?
Yes.
Okay, everybody. So I'm going to talk probably for about 12 to 15 minutes, and then we can have some time for question and answer. Let me know if you can see my screen here.
We can see the screen.
So the title that was submitted was Seeing is Believing, but if I want you to remember two words from what I'm talking about today would be image guidance. And by way of introduction, I'll tell you that we have a program that we started here several years ago called PI3, which is the Program for Intelligent Image-Guided Interventions, that I'm encouraging all of you to get involved with this. And I'm happy to be able to talk to some of our colleagues in our affiliated hospitals. Maybe you're familiar with we talked a little bit about young people in the Queens community and elsewhere, but you all know that GI disease a few years ago overtook heart disease as the #1 cost expenditure for the U.S. government. I want to go on to say, if you sit down and think about, like, where should we go, where should we try to make progress, that the concepts that we apply now to the treatment of GI disease, and it's not true, as I'll say in some of our other specialties, but the concepts that we're applying to treating things like cancer are probably more related to the 19th and 20th century than they are to the 21st century, okay? Image guidance, there's nothing new or novel about that. This just shows an early, X-ray room that's in the National Library of Medicine, a photograph there. There's nothing novel about me talking about image guidance. Like, doctors of every specialty are always curious and interested in looking inside the body. Some of you may know these two surgeons looking curiously in the 70s into somebody's mouth. Dr. Bursey and Nejat, both of them big members of SAGES, as you may recall. And going on from there, this is another doctor in that same time period looking for new ways to look inside the body. This is Dr. Sem in Germany, where he actually attached his small laparoscope, you can see there, to his head in an attempt to allow him to look inside the abdomen, obviously, antedating what we do now, which is look on screens. And, think about this for a second. Maybe one of the most important things that laparoscopy did was taught us to start using screens to treat patients, because prior to, we really hadn't been doing that. And so one of the revolutionary aspects of laparoscopy
Jeff, you're frozen. Wait a little bit. Oh. See if he's logging in again. Yeah. We can see the screen, but we cannot hear you.
Okay, we're back on. We're back on.
Yeah, we don't see your slides.
Can you hear me?
Yes.
All right, I'm working my way forward. How are we doing? Alessandro, can you hear me now?
I can see you and I can hear you.
Okay, can you
We
see my
gotcha.
slide? You got me?
You and your slides. We got you.
Yeah.
Beautiful. All right, sorry about that. I don't know what happened. Okay, and so I'm just going to carry on. When I saw that cardiologists, 10 or 12 years ago could actually put a valve into the aorta by puncturing through the groin, and saw the difference that this sort of made in the outcomes of patients having aortic valve problems, I understood and believed that we as GI surgeons needed to start thinking about other approaches that we should take. This is a German colleague of mine who's actually using, again, image guidance to completely reline the aorta from aortic arch down to the aortic bifurcation. And you can see what he's doing is not in any way what you would have called vascular surgery 15 or 20 years ago, but he's using image guidance here in the OR. You get my point. What's happening in navigational bronchoscopy? This is Eugene Shostak's talent here. Some of you may know Dr. Shostak, but same thing. He uses the combination of image guidance with his bronchoscope tip to identify a lesion and then take a biopsy of it. This is just taken from his website in order to do lung diagnostics and therapeutics. And some of you may recall, I had a eureka moment about 4 or 5 years ago. Mike Lieberman here had a patient who was 3 weeks post-op, a right colectomy, who had a bowel obstruction, where he thought it actually was obstructed at the anastomosis. The patient was walking around on 14 North here with an NG tube in place. She was not a youngster at that time. And so I decided, he asked me to do a colonoscopy thinking that its anastomosis might be stenotic for some reason. But what I discovered, the anastomosis was wide open, but by using fluoroscopy at the time, which I fortuitously thought about using, you can see I'm now creeping into the small bowel, injected some contrast, and you can see there's a kink right here that you see on the screen. I injected the contrast, and as I put a guide wire through there and then railroaded the scope over the guide wire, what you see happen was that all of a sudden the scope straightened out, and I went up into a dilated loop of intestine, which this is another patient from around that same time period. You can see up here it's from 2020, where we were able to navigate up to the area of a distal small bowel obstruction. And what we saw was, as you got through this area, was there's the obstructed bowel. Okay? And I'm just going to keep pounding away at those words. Image guidance. This is not fancy high-tech image guidance that we started off doing. Going on from there, I'm not going to go into this in too much detail. We've also had some luck getting at the gut percutaneously. This is just some work we did in our labs that showed that you can access and you can close with endoscopic clips percutaneous access. But the case in point, this is just a patient who had a very large polyp in the cecum, right adjacent to the ileocecal valve, going around a corner, and using percutaneous access, which is something we've also had success in treating a variety of different lesions at. These are just vascular sheaths that we punctured in through the bowel, and we're actually using the endoscope as a camera inside the gut. But this was a polyp that was about 6, 7 centimeters in diameter. We went through this, and of course, very talented interventional gastroenterologists can take these things off. But I took this thing off in less than an hour and kept the patient overnight. Patient home the same day. Patient went home the next day, excuse me. Lesion was benign, and that's the lesion. Put clips on the mucosa at the end, and then put clips from the inside of the bowel where the access sites were. So I'm just going to try to define for you what I think image guidance is for us now and in the future. But it's using things we're already doing to improve outcomes or safety. Some of these things are readily available, and you know every day in both in any of our hospitals that vascular, neuro, and orthopedic surgeons are using image guidance to a much greater degree than we are. But we need to get started, and I think some of you already have. We use image guidance if we take the pre-op CT scan and calculate where, let's say, if somebody needs a stoma, this is a patient of mine, where we made a mark on the patient's tummy based on where her belly button was in the CT scan, and it was a different spot than where the nurse made an ostomy mark. Thankfully, where we decided to do this was directly corresponding to where the transverse colon was. This is a rectal cancer patient who needed a stoma. There are other examples like using image guidance, just taking your CT scan. This is just a desperately ill patient who needed a diversion with a small bowel obstruction from carcinomatosis. Just taking a ruler after you use a caliper on the CT scan and taking a body landmark, you can, nothing else fancy, just calculate that, and having a ruler and a marking pen in the OR, that's using image guidance for you to make an important therapeutic decision. The other thing that everybody has, every hospital has portable fluoroscopy that I think we don't use frequently enough. This is just showing a case in one of our ORs, OR 23, where we have brought this in for a similar type of procedure. And this is easy to set up. And it's a workflow issue that once you start learning how to do it, it's very easy and simple to do. So this is an example of creating a stoma, again, in an unfortunate patient. This with a colovesical fistula. I'm using image guidance. I've filled the colon with carbon dioxide, which is a contrast medium. And you can see where I have those large scissors superimposed on the patient. That's where we want to make the stoma. We were able to easily get a scope up to that area. But by simply doing that, we knew exactly where the stoma could be created. You don't need laparoscopy in a case like this. You can just do a cut down. This is a separate patient. This is a patient of Dr. Shu here, who's one of our trauma surgeons. Most of you know him from the other hospitals, where he asked me to try to care for a patient with a bowel obstruction. He had operated on 3 times since 2020 for bowel obstruction, each of which was accompanied by a lot of misery on his part, saying dense adhesions, serosal tears, inadvertent enterotomies, and now he had a new obstruction. I thought I was going to be able to access this potentially through the ileocecal valve, but I couldn't get into the gut. And so what I did, and again, we consented the patient to quote unquote do whatever we needed to do. But what we did is using fluoroscopy, you can see the scope, and you can see in this area that there is like a transition point in the right lower quadrant. We cut down with about a 5 centimeter incision. We passed a balloon through this area. We up and downstream and injected contrast, and we were able to open up the obstruction. The patient had a very small incision. He had no bowel resected, and he went home about 3 days post-op with a remarkably benign post-op course. This was image guidance used to do a limited laparotomy. This is something any of us are capable of doing if you think it through. I'm going to move to like some of the other uh, contexts in which we've tried to do image guided procedures. We do sometimes use a vascular room. This is one of our rooms that has the capability of doing cone beam CT, which can give us a 3D. The center screen you see is one of the slices from the cone beam CT. This can give us a 3D representation of where a problem in the gut might be. You can see there's a doctor on the right with an endoscope, doctor on the left, uh, who happens to be one of our interventional radiologists, where we're working together to solve some of these more difficult problems. We also borrow technology from the vascular surgeons. This is a patient of mine who had a very proximal small bowel obstruction where you see the arrow, um, very hostile abdomen, many laparotomies, free flap overlying where this obstruction was in the abdomen owing to the prior operations that he had. But he's got a bowel obstruction. So vascular surgery tech, which they use for us, which they use to superimpose the aorta, reconstruct the aorta, we're doing the same thing. We're doing a segmentation of that kinked area that I had the yellow arrow on. And lo and behold, let's say we were lucky, we planned it in advance, but I was able to take a colonoscope through the stomach and into this area in the proximal jejunum and free this up using a trans colonoscope guide wire balloon. And the patient went home later that day, the same day that we opened the obstruction up. Um, but the technique of how you disrupt these is one where you're going to follow. I'm just showing you briefly. You're going to see this kind of a kink generally, that you can see that waist in the middle of the balloon. You then see this open up. It's very much like what you see in vascular. You see there's like a little pop like this, and then you tend to run the balloon back and forth through that area. Again, you need certain tools, most of which are readily available. This is a case example of a patient who had a J pouch who had a similar problem, where I have a little bit better documentation, where you see in the right lower quadrant she has a transition zone going from dilated to undilated bowel, which we thought was within reach of a scope as well. You don't need a lot of fancy equipment if you're going to try to do these types of things. And so in the OR, with an endoscope, with a colonoscope, with fluoroscopy, and with the balloon and guide wire, there we came to this area, and you could look at that area and say, well, maybe she's got Crohn's. Maybe this isn't really an adhesion, but um, you're able to thread using the techniques that we've learned and adopted. All of you have probably done something similar to this. You can see us blowing the balloon up, uh, then pushing this back and forth, kind of making sure that it's wide open, and then actually driving the endoscope through this area back and forth to be sure that you think that it's open, to be confident that the adhesion is open, is what we do at the end. And then this is doing just that. We're driving back and forth. Unlike Dr. Fakir and I had a case where we knew this wasn't going to work, but you have to see that it's wide open like this. And then again, you look at it and you go, well, is that really an adhesion? Okay, it looks kind of, maybe it is. She had a J pouch for colitis in the past. Okay, we also injected. This is just showing injecting a free flow through there, but just I'm trying to move along. So these first three images on the bottom are what you saw at the initial operation. 6 months later, she's in the office. This area that you see is the area where this was, and you can see it's completely benign, and the patient has continued to do well. This kind of a approach to adhesive small bowel obstructions using image guidance is one we've done now in, you know, several dozens of patients, thankfully, without any perforations or bad complications. Technical success has been high, and overall, with a recurrence rate that's well over a year now, we have about an 81% success rate in treating these. Like, getting more fancy. That patient that I just showed you, we have the capabilities now, and we're branching out with our thought processes on how we're going to be able to treat lesions better. This was the transition zone that you saw. You can see the ileal pouch down below. And we're learning that using 3D reconstruction in these patients can be something that could also pave our way to treating other types of diseases more successfully. 3D reconstruction, we have an open source software. It's called 3D Slicer. Some of you may have heard of it. This is one of our first cases where we started learning about this. 3D Slicer is where your CT scan data is uploaded onto this uh, software. You get a rough sort of look at the intestine and the other things like the bones. This first case is like a case in point. This is where we had an enlarged lymph node next to like a chronically incarcerated hernia in the groin, and we're illustrating how we are now taking this 3D reconstruction from the CT scan, and we can superimpose that on the patient. Now, how hard is this? Well, it's becoming increasingly less difficult. And then you're seeing the images here using a HoloLens 2, a Microsoft product that some of you may be familiar with, that's used in gaming and other things and used in some industry. And this is something that we're looking at and evaluating how it can be used in the OR successfully. Um, This is Adam, one of our fellows from a couple of years ago, where we're using this same sort of technology, where he's marking on the skin where the colon is that we've done a preoperative segmentation on. Again, just very similar to what vascular surgeons are doing, and looking at these fancier image guidance methods and see how they may impact on the outcome. Um, This doesn't work for everybody. We did a similar thing. This is a recent patient of mine who had a chronic intermittent small bowel obstruction, numerous uh, admissions. Um, in this case, it was kind of like Alessandro and I had a shared case where you see in the right there where you see the green um, marks, there's like a kink where the obstruction is, and this patient had a swirling. You see how there's like a swirling kind of motion there. So we made a 3D reconstruction of this patient. I'm not going to show it to you for the sake of time, but I was a little pessimistic that we were going to be able to do anything. We actually made a drawing on his tummy at the time of operation. You can see his numerous previous scars, and the X marked where this swirling area was. And I just chose at the beginning to make an incision in the upper abdomen, and you can see this wasn't going to lend itself to a balloon disruption. The swirling was a result of a twist and then fixation of the gut related to his adhesions from his prior surgery. So I'm going to move on and just talk to you about some of the things that we're working on related to image guidance. Again, 21st century technologies, applying it to the diseases we're now treating. And we believe in our center that I'm working with that imaging, using data, using AI, which some of which you saw on the images that we're creating, and new tools are going to pave the way to some of the therapies. This is a company that we're working with that uses uh, augmented reality that helps fuse pre-op CT scan with live intra-op ultrasound, this is a phantom model that I'm illustrating. Uh, uh, in actually Dr. Pua's office. He's our chief of interventional radiology. And the purpose of this sort of image guidance is to show you, so you have these are little balls which are supposed to be in the liver and some blood vessels that we now have the capability. This is just us going through setting up what's called a needle guide. And that if you look at that little green arrow, we now have the capabilities that we're going to be able to target a lesion percutaneously like this. And actually within 1 millimeter or less, you can see when I get on the target, that little green ball that little green ball is the tip of the needle, and I can puncture right into that little orange ball that allows us to very, very precisely and accurately target a lesion. And we have a number of therapies that we're looking at that will permit us to do some of the surgeries that we do even under local anesthetic. We're looking into other things like this is the Meta Orion augmented reality glasses. This is called FORCE technology. It's a means whereby you're going to be able to use catheters and guide wires inside the abdomen without the need for fluoroscopy and know exactly where you are, superimposing these onto the screen, onto a 2D screen, or let's say a laparoscopic or endoscopic screen. We're looking at ways of capturing and puncturing into the intestine percutaneously. This is one tool that I'm one of the people who founded a company that's looking into this technology. And I'm just going to wrap up by saying image guidance, the pathway goes through things we have now that you have the capabilities of using. We all have the capability of using our pre-op CTs to better advantage. We have the capability of using endoscopes, fluoroscopy, and contrast in our what you would call day-to-day simple procedures, simple and complex procedures to create better outcomes for patients. There's fancier equipment that we're using like cone beam CT, the vascular room, and the use of 3D segmentation and things like needle guide. Needle guide is the superimposition of a track or a target onto the screen like vascular surgeons use and interventional radiologists. And then I briefly outlined the future that I see coming very quickly, where we're using AR and AI and software increasingly around the OR that's going to help us define percutaneous access and other endoluminal needle catheter guide wire techniques that are going to help us change the direction of colorectal surgery much more into the 21st century. And so I want to thank the other people on our team, on the PI3 team, Dr. Pua and Dr. Art Sadrakian, who's in healthcare research. Why? For the obvious reasons that we want to improve outcomes, be safer, and lower healthcare costs. And with that, I'll stop and answer any questions.
Great. Thank you, Jeff, very much. I see Dr. Samstein already has his hand up.
Good.
Um, Jeff, this is great talk, and technology, image guided technology is great. Um, recovering from surgery, one of the primary complications is about leaks. For those of us who put two circles together, leaks and from those circles really cause a great deal of complications. Pancreas, liver, bowel,
Blood
all.
vessels.
Well, blood vessels are easy in some ways because the volume of blood enables you to see bleeding in the OR. But colon, we try a whole bunch of techniques to try to anticipate a leak. We insufflate with air.
Put a scope in there.
Yeah, I was wondering if you might comment. Are there any, um, you know, I know there's ICG, but any other technologies that you think might, if we could do Whipples without leaks, for example, in HPB surgery, the mortality and morbidity of a Whipple would be dramatically transformed. It's a bioleak after a liver resection that kills people, and it's obviously colonic anastomoses and leaking that really kill people.
Okay, well, there are technologies that image and image guidance may or may not solve the leak problem, but it probably will tell you earlier that you got a leak, right? There are catheters that Dorna, aren't you driving? If you're on this called, there are drains and other things that people are putting that give you early warning that there's a okay. Um, you might know, and this is not related so much to image guidance, but it's related. Well, it is related. We are using cells here that Shaheen Rafid has developed and commercialized. The company is called Angiocrine, that we've had about a 70% cure rate of treating anal fistulas. These are super revved up umbilical vein endothelial cells that we're injecting. And so there are means whereby I think we can improve the healing rates of all these types of hostile anastomoses by other forms of 21st century technology. Um, the things that are germane to like imaging, also, if we can put, sometimes what we do is we wait till the patient gets sick, right? Before we do certain tests on patients, like CAT scans, right? And I'm not saying everybody needs a prophylactic CAT scan or that would even be needed, but imaging might play a role because we now have tiny, tiny cameras also that can be placed in like a needle puncture using image guidance so that you could go look at your bile duct anastomosis in the right upper quadrant, probably with a needle stick under local even. So, and again, combining that with some of the other uh, tools that we have that I mentioned, including ultrasound. So there is a road forward on all that. As well. You're right. I think rather than being reactionary doctors, in colorectal, we sometimes the patient's doing fine, and then 3, 4 days, 5 days later, they're not doing fine, and you're behind the 8 ball already.
Well, if we came to a world where you were confident of your anastomosis, you need a lot fewer stomas.
Absolutely. Unfortunately, it's not, as many people have also made the point, I'm sure it's true as well in biliary and pancreatic anastomoses. It's not necessarily the intactness of the anastomosis when you finish. It's what happens.
Right, 3 days later.
Yeah, like whether it's an infection or lack of blood flow.
Yeah.
That's why these other things like revved up cells that promote healing may be a way forward there.
And any other questions for Dr. Milson? This was an amazing talk. You will never stop thinking. And that's remarkable. Any other questions from the group?
Everybody must be tired and hungry too.
Yeah, we started at 7:30 today. This was a full day of innovation. We started from the future of rectal cancer surgery. We talked about ctDNA. We talked about the maximal invasive surgery with Dr. Jafari, minimal invasive surgery with Dr. Foglia, where we take our program in terms of disparity, in terms of reaching out to the community. We really covered a lot. And then the icing on the cake was this talk on all these new ideas and innovation for the future. A transplant for liver metastasis. So it was a full day. I personally learned a lot. I want to thank you all for coming and the attendees for sticking around. There will be a CME offered. If you register, you will receive an email with instructions. and the talks have been recorded and will be put on the website individually. That's why we did individual recording, so you don't have to go through 5 hours of recording to find what you need. Any other comments from the panelists?
Thank you for organizing this, Alessandro and the team, Diana, etc. It's great. It's great to hear what other people are doing too.
Great. That's it for today, I believe. Stay safe this weekend, and we'll see you soon.
Have a good weekend, everybody.
Thank you.